Investigation of death associated with anesthesia and surgery. Team. There should be an anesthetic and surgeon from a different hospital in the investigating team to assist in the investigation. In case of a special surgical death, obstetric, neurosurgical, pediatric death, or etc., a specialist from the concerned specialty should be included. Question. Before starting an autopsy on a case, the investigation team must ask itself the following question. In case of doubt, a clarification may be sought from an independent surgeon or anesthetist. Was informed consent obtained for the operation and administration of anesthetic? Was an operation or under the administration of anesthetics necessary in the circumstances? Was it essential to save the life of the patient? Was the patient properly examined before the operation? Was he fit to undergo the sudden anesthesia and surgical operation? Did the patient have any predisposing condition which made him susceptible to death from the operation or anesthetic? Was the patient suitably prepared for anesthesia and surgery? Was a suitable form of anesthesia administered? Were all anesthesia equipment in proper functioning order? Was there any mislabeling of anesthesia or oxygen? Was anesthetic administered to surgical operation performed by properly qualified and trained personnel? Was there any defect in the surgical anesthesia technique? Were suitable and adequate arrangement made before the operation to deal with any surgery which might arise from the administration of an anesthetic? When the emergency arose, were suitable steps taken immediately to resuscitate the patient? Were suitable and adequate arrangement made to ensure the safety recovery of the patient? Would the patient have died without the operation or anesthetic? Exclusion and reasoning. It must be kept in mind that many anesthetic deaths are of physiological nature only, or which and may be virtually impossible to detect. Cardiac arrhythmia, fall of blood pressure, glottic spasm, vagal inhibition. Opinion must be based on autopsy finding as well as exclusion and reasoning. Preliminary investigation. Visit to the operation room. Check all requirements, preferably in a consultation with an independent anesthetic from a different hospital. Check all valves and containers to ensure that there was correct mixing of percentage of gases. History. Obtain a history of exposure to relevant and potentially toxic chemicals during the prior period to hospitalization, hospital stay, pre-anesthetic preparation, anesthesia. Obtain list of relevant and potentially toxic chemical associated with each of these periods. Thorough review of hospital chart. Hold discussion with the surgical and anesthetic team. Existing disease, a condition requiring surgery. Some surgical conditions are high risk per resection of the aortic aneurysm repair. Surgeon may not be able to control bleeding. Other pre-existing conditions. Some contraindication to operative procedures are not easy to identify. Sometimes they are identified, but their seriousness is not appreciated. Anemia, hypertension, serious symptomless coronary artery disease may prove fatal due to increased anoxia by anesthetic agent. Brown atrophy of the heart, bronchitis, emphysema, interstitial pulmonary fibrosis, endocrine, myxedema, thyroid toxicosis, anesthesia, pre-anesthetic medication, over medication, no medication, wrong medication. Anesthetic agents. Get information about anesthetic agent used. Check if method by administration was correct. Inadvertent wrong mixing of anesthetic agents may have occurred. Note duration of time the patient remained under anesthesia. Was it excessive? Equipment. All equipment including containers, valves must be checked in association with the appropriate qualified personnel. Check if a correct mixing of gases was ensured. Miscellaneous condition. Blood transfusion. Investigate mismatched blood transfusion, burns or explosive causes. Rare cause of death due to anesthesia, shock and hemorrhage. Resuscitative measures. Not all resuscitative measures. Autopsy. Examine all devices in situ. Devices attached to and inserted into the body must not be removed either by operating surgeon or nurse before sending for postmortem. Common indwelling devices encountered are airways, chest tube, indwelling catheter, needless intravenous cannula and wound drains. Autopsy pathology should open cavities with the device in situ to know whether the other end was reaching. Intubation devices may be in the esophagus, thoracic drain pipe, or maybe puncturing lung, etc. All devices must be checked for patency also. Fluid in each cavity. Note presence, smell and volume. Preserve for analysis. Examination of operation site must be thoroughly examined, although at times it may be difficult because of surgical alteration of the anatomy as well as because of the presence of the hemorrhage, adhesion, sepsis, edema. Look out for an artificial findings. Sutures from a stomach and intestine may appear to have broken down. It may, however, be an autolytic changes, surgical errors, ligation of an prong vessel, ligation of coronary arteries while implanting a heart valve prosthesis, inadvertent ligation of ureter bile duct, perforation of large blood vessels, inadvertent removal of a vital organ, order of anesthetic agent in case of inhalation anesthesia. All surgical sutures, external and internal, must be examined whether they are intact or given away, whether infected, etc. Viscera, engorgement of dependent parts cannot be laid upon a sign of prolonged anesthesia. Such findings may be seen after death due to passive gravitation. Heart, detailed examination, histopathology may reveal myocarditis, brain, hippocampal gyrus, and cerebellum shows hypoxic changes. Ammons horns, cornua ammonis, hippocampus are particularly vulnerable, especially the somer sector region CA1 and to a slightly less extent end folium. The selective necrosis in the somer sector may be identified macroscopically if the patient survives for more than few days. Diffuse severe leukoencephalopathy of cerebral hemisphere with the sparing of immediate subcortical connecting fibers, demyelination and obliteration of axons, infarction of basal ganglia. Damage is limited to white matter. Diseases for which operation was done. Check evidence for it. Check for common causes of intraoperative death. Dictatable asphyxia from aspiration of regurgitated material, embolism, air fat. Evidence of anaphylaxis and hypersensitivity, internal hemorrhage, peritonitis, retained instrument and swab, undetectable cardiac arrhythmia, fall in blood pressure, spasm, coronary artery, laryngeal vagal inhibition. Samples to collect. Blood for grouping, matching, etc. Blood collected for diseased transfused blood, empty and half empty blood bag for culture exudate plus samples from all organs. Histopathology for toxicology. Both lungs must be tied and submitted for toxicological examination. Other viscera are in a standard toxicology death. Alveolar air collection procedure in which gas from cavities, heart and blood vessel fill body cavity with water. Use a rubber dam to trap gases before cutting the organ. If specimens or cut tissues are collected in a routine fashion, gaseous and volatile anesthetic may be lost due to exposure to air. To avoid such losses, it must be necessary to obtain samples by biopsy techniques prior to autopsy. This includes in situ encapsulation or freezing, direct transfer of specimen from the body into hermetically sealed airtight containers or analyzing solution, sometimes even direct transfer to tissue in the gas liberating module of an analyzing instrument. Many toxicological agents may not be detected despite having contributed to death. Thus, failure to detect does not include the possibility of death due to the injection site, local anesthesia, extraneous specimen other than those from the body, medication containing residual solutions, samples of gas used in anesthesia, samples of operating room in air. Legal aspects of anesthesia. Legal responsibility of an anesthetic role during illegal surgery. It is the duty of anesthetic to refuse anesthesia during illegal surgery. Illegal MDP, organ retrieval, amputation of healthy limb for making burgers. He cannot claim he did not know the nature of his surgery because during the anesthesia checkup he must be discovered. He must be bring to the notice of legal authorities. If he administer anesthesia during illegal surgery, he is a party to crime. Thank you.